Good evening, everyone. My name is Dr. Kunal Amin. My co-author is Dr. Priya Agarwal. We are both second-year PG residents from Maharashtra Markandeshwar Institute of Medical Sciences and Research in Mulana, Ambala. Today, my topic is the role of ultrasound in musculoskeletal soft tissue masses. Let's begin. There are many reasons why you would do an ultrasound in MSK soft tissue masses. This is to know the extent of the mass, to know the nature of the lesion, to understand the relationship of lesion to the adjacent structures for a foreign body retrieval. It can be used for guiding a needle for diagnosis or aspiration purposes. It can be also used to differentiate between pseudotumor and a true tumor. In soft tissue masses, we look at the ganglion cyst, which is a mucin-filled lesion most commonly located at the scaphoid lunate articulation. It is mostly related to the joint or tendon sheath. On ultrasound, we see a well-circumscribed oval or lobulated anechoic cystic mass, which may or may not show low-level internal echoes. A neck is usually visible, extending from the lesion to the underlying joint or tendon sheath. On Doppler, it shows no internal flow. In the Baker cyst, a cystic lesion is seen, which is present in between the distal semimembranous tendon and the medial head of the gastrocnemius muscle. It has a narrow neck arising from underlying knee joint, which can sometimes act as a valve, leading to fluid accumulation within the cyst that can rupture, leading to pain, swelling, and erythema behind the knee, and it can extend to the calf. The ultrasound findings of a Baker cyst are: in an uncomplicated cyst, it shows anechoic simple cystic lesion, which is seen in figure A, and in a complex cyst, it shows heterogeneously hypoechoic cyst containing fluid or hemorrhage, septations, and debris is shown in figure B. Now moving on to lipoma, which is the most common palpable soft tissue mass. This may occur within the subcutaneous tissue, muscle, or deep soft tissues. We look at the simple lipoma, which can present as a painless, mobile, compressible lesion. On ultrasound, it's seen as homogeneously isoechoic or slightly hyperechoic to adjacent subcutaneous fat. It contains thin echogenic septations that are parallel to the skin surface as shown in the image. On Doppler, it never shows any hypervascularity or hyperemia. Moving on to the intermediate lipomatous lesion, this is painful. It usually is over 5 centimeters in size and gives history of enlargement over time. In ultrasound, it's seen as a complex echogenicity and it shows deep acoustic shadowing. On Doppler, we see hypervascularity. This needs to be passed on for MRI to rule out possibility of liposarcoma. Then we move on to fat containing hernia, which changes in appearance over time or with the Valsalva maneuver. Now we look at cellulitis, which in early stages, the skin and the subcutaneous tissue are thickened, seen as hyperechoic compared to the normal subcutaneous fat, shown in figure A. Now this is effectively treated by antibiotics, but it can move on to as seen as interdigitating interstitial inflammatory exudate, giving reticular strands of hypoechogenicity, which we call cobblestone appearance. Then it can progress to an abscess if not treated, in which case on ultrasound we see anechoic or hypoechoic complex collection with internal septations and low-level echoes and swirling of echogenic debris, which is pathognomic or in an abscess. It can be surrounded by a rim of thickened soft tissue, and on Doppler there is hyperemia of surrounding soft tissue. Moving on to foreign bodies, in this metals and glasses are radio opaque and can be seen on plain radiographs. However, for objects like wood, ultrasound is helpful. On ultrasound, it is seen as highly echogenic and produces posterior acoustic shadowing. It may be surrounded by a hypoechoic halo, as shown in the attached figure, which can also be hyperemia on Doppler, representing surrounding inflammatory reaction. We move on to nerve sheath tumors, which are usually benign masses. On ultrasound, they are seen as well-circumscribed, solid, hypoechoic, vascular or avascular masses with contiguous nerve of origin passing through. Here we see a non-encapsulated mass in a case of neurofibromatosis, and we see a well-encapsulated mass in the case of schwannoma. The ultrasound features are poorly defined. It can also show internally heterogeneous in appearance as a result of internal necrosis or hemorrhage. On Doppler, it shows internal vascularization. Move on to nerves and its lesions. Nerves usually show a characteristic honeycomb morphology on cross-section, and in longitudinal axis, they show internal striated pattern as seen in these two images. Moving on to the pathologies, we see a case of nerve compression in carpal tunnel syndrome, in which the median nerve is compressed at the level of the wrist. On ultrasound, within the carpal tunnel and at the palmar aspect of wrist, you can see compression and flattening of the nerve just proximal to the tunnel, which can be seen as swollen and expanded. The diagnostic criteria for this is a difference of at least 2 mm squared between the two measurements. We see a case of subluxation of nerve on ultrasound. It shows on wrist there is an extended elbow in which the ulnar nerve is positioned posterior to the medial epicondyle of the humerus, and on flexion, ulnar nerve dislocates anterior to the medial epicondyle along with the medial head of triceps as shown in these figures. This can be also called snapping triceps syndrome. Then we move on to tendons, in which in normal ultrasound, in cross section we see homogeneous stippled appearance, and in longitudinal section we see a highly organized echogenic linear fibrillar or striated pattern. Now we will talk about a phenomenon known as anisotropy. In this, while performing ultrasound, collage and bundles, because of their smooth parallel organization within tendons, act as specular reflectors such that sound waves are reflected in single direction. When these specular reflectors are imaged on ultrasound, if the angle of insonation is not perpendicular to the fibers, sound waves are reflected away from the transducer, leading to generation of artifactual hypoechogenicity as shown in figure A. This can be corrected by keeping the transducer at 90 degrees over the artifact as shown in figure B. We move on to tendinosis, which refers to the intratendinous degeneration without tearing. This most commonly occurs in the Achilles tendon. On ultrasound, we see areas of hypoechogenicity in the normally echogenic and fibrillar tendon, associated with varying degree of the tendon thickening as shown in figure A. On Doppler, there is neovascularization seen. Now we see a case of tendon tear. On ultrasound, discontinuity of the fibers as hypoechoic or anechoic gaps are seen, which is shown in the figure underneath. There can be also focal thinning of the tendon. There can be also a small hematoma present. In complete tear, there is non-visualization of the retracted tendon. And on Doppler, there is hyperemia of the injured tendon as seen in figure B. Moving on to tenosynovitis, this refers to the inflammation of the tendon sheaths as an overuse phenomena or as a result of rheumatoid arthritis. On figure A, we see the peroneus brevis tendon in patients with rheumatoid arthritis. The tendon appears thickened and heterogeneous. It also shows increased fluid volume, which is seen as the hypoechoic content, around the tendon within its sheath, as shown in figure B. This is a case of de Quervain's tenosynovitis, which is also known as radial styloid tenosynovitis. Moving on to ligaments. Normally on ultrasound, these are seen as fibrillar appearance, and that fibers are more densely packed than those in tendons. In a ligament sprain case on ultrasound, the ligament shows swelling, hypoechogenicity, and some loss of the fibrillar pattern as given in this diagram. These are my references. Thank you very much for your time. Merry Christmas.